Okay, thanks, Colin, for bringing that up. We're going to hold off just a sec here. There's Mira and Natasha from Boston. Welcome, folks. And in fact, it's in some ways a good segue because, as you know, Boston is one of the expansion grantees, and I am the lead on early childhood for the TA network, and part of what I do is I'm talking to current grantees, the expansion grantees. I actually invited some of the alumni as well. And one of the questions that we had gotten was around how are folks paying for services provided by family partners. And so I'd asked Jane Walker to join us. So Jane's going to start up here in a few minutes, but I just want to, as folks are joining, thanks, Douglas. Welcome. Some more Oklahoma folks. And your lines are unmuted, so just remember that as you're sort of joining. Janice is also from Oklahoma. Thanks, Janice. Just keep in mind that we can hear you if you start having a conversation. We're happy to have a conversation if it's related to what we're talking about, but if you actually have to do something in your life related to your family, to your work, other things like that, just remember to put us on mute for just that little bit. So again, for those who are just joining us, this is Neil Horn from the TA Network, and we're just going to wait another minute as folks are joining. If you're joining, go ahead and type in who you are, where you're from. We'd appreciate that. Just sort of get a sense of, who's on the phone with us. And we're going to get started here. I see a couple more folks are typing in, so we appreciate that. It helps us get a sense. And as you know, this is sort of an open call. We obviously are trying to gear it towards folks who are in the midst of developing their systems, and for me, obviously, it's around their systems related to young children and their families. That's my sort of bailiwick. I don't know what bailiwick means, Jane, but I thought it was a good word in the moment. So I'm focused on those systems that are dealing with young children and their families. Doesn't mean it's not germane for other folks, and we're super excited to have folks who both have some sort of system of care grant, an expansion grant, thinking about getting one, had one, don't have one, don't want one, but are doing some systems work. So we're going to spend the first part of this call really talking a bit about how family partners who provide services, how those are supported, how those are funded. We're lucky to have Jane Walker join us. And then, assuming we have a little bit of time left towards the end, we can also have a more open discussion about other topics if folks are interested. Remember, this is our monthly call just around early childhood issues. So with that, I'm going to turn this over to Jane Walker. Jane is somebody that I've known quite some time. I think Jane actually lives around the corner from me somehow, somewhere. And I've known Jane since our work in Maryland and Jane's leadership at both state level in Maryland and obviously now at a national level. It's been great to watch not only Jane's work, but all the other folks that I've met either through Jane or in association with Jane. And Jane's going to do a little PowerPoint. We'll do some Q&A. If you have stuff that comes up, feel free to type in the chat. Thanks, folks, for continuing to type in there who you are and where you're from, Deetra and Kelly. So with that, Jane, I'm going to turn it over to you. And folks, just remember, if your phone lines are open, so if you're talking, we're going to hear you, but we certainly will have time for Q&A after Jane does a little PowerPoint for us. So take it away, Jane.
Okay, Neil, thanks so much. And hello, everyone across the country. I have to tell you, it's blasted hot here today and humid, like you would just melt going outside. So I hope wherever you are, it's a little bit cooler and much less humid than it is here in Maryland, where both Neil and I are. He's right. We live only a few blocks from each other. But anyway, welcome, and thank you, Neil, for inviting me to participate on this call. I'm going to tell you a little bit about myself because it's pretty relevant to this topic. So I'm the mother of 5 children and also the grandmother of 5 children, although you'd never know it to look at me. But our second oldest daughter, from a very young age, had mental health and behavioral needs. And I so remember taking her to a pediatrician and saying, I just don't know what to do here. And it's horrifying to me now to think, but the pediatrician actually prescribed some pretty heavy-duty medication for her, which the first time I administered it, she crawled under the bed and refused to come out. And she was maybe 2 years old at that point. And it terrified me, so I never gave her that medication again. And I don't think she ever should have been prescribed that medication. But we went from place to place to place to try to get help and just have somebody listen to us. So I feel that my heart is with this early childhood mental health. I think it's been so tremendously underserved, and perhaps now with people like Neil, it's getting a lot more attention than it had been. So thanks to Neil and thanks to all of you. I often think how our trajectory of our daughter's life and our life might have been different had we been able to get help when she was 2 years old instead of when she was 12 years old. She was sent out of state to residential care. So know that what you are doing is so, so critical to a child and family. So thank you. So now you see my name there, Jane Walker, Executive Director of FREDLA. Well, what the heck is FREDLA? FREDLA is an acronym for a very long name of an organization called the Family Run Executive Director Leadership Association. FREDLA was started in 2013 by 16 leaders of family-run organizations. And so we represent a network of family-run organizations across the country. So what is a family-run organization? A family-run organization is an organization where the board of directors is more than 50% family members with lived experience. We're going to talk about lived experience in a minute. It means that the leadership of the organization and the direct service staff of the organization are also family members with lived experience. And lastly, it means that the mission of the organization is to support other families of children with mental health needs. SAMHSA has funded a network, and many of these organizations started through System of Care grants. And now we estimate there's around 110 to 120 organizations. The number kind of fluctuates. So we are a network of these family-run organizations. And we've been doing a lot of work in the peer support area, which is why Neil invited me to join you on the call today. So he's already mentioned that this is being presented by the National TA Network for Children's Behavioral Health under the University of Maryland, and I am with FREDLA. We are a partner. So let's talk about the definition of parent peer support. Primary caregivers, so that could be parents, adoptive parents, foster parents, kinship caregivers who have lived experience of being actively involved in raising a child who experiences emotional, developmental, behavioral, substance abuse, or mental health challenges. So they've walked the walk. So the most important criteria for a parent peer support provider, and we're going to use the term PSP throughout, although there are many terms, and I'll mention a few of those in a minute. PSPs have the experience, what lived experience then means, is of actually navigating the child serving systems to access services and supports for their own child. But in addition to that, that's not sufficient. It means they've also received specialized training to assist other families and empower them who are also raising a child with similar experiences. So we consider lived experience to be the primary but not only criteria for someone to become a parent peer support provider. I mentioned there's many names, different states call them different things. Family peer support providers, advocates, mentors, navigators, support specialists, But again, and I'll go back to this many times over, the lived experience is the most important factor. So there's lots of roles for parents peer support providers, and I consider one of the most important ones to be reducing isolation. So often families feel, and I'm preaching to the choir here, cut off from any socialization with neighbors, often family members, because of their child's behavior. They're not welcome to join in parties. Their child's not welcome, so they feel very, very isolated. So when a parent peer support provider connects with a family, you can almost feel the connection. It's so immediate. And so that's a key role. Secondly, to inform, interpret, and educate. We can explain processes and procedures to families who don't know how to navigate systems. We interpret information for them. I know I didn't mention that I started and ran the family organization in Maryland for 14 years. And we would get reports that families would bring to us, and we would go over them and be able to review them so the family understood what they meant. Certainly advocating and navigating complex systems, but also promoting positive parenting skills. Some sites, I know, actually the family organization has people who are trained in some of the parenting programs, certified in those, and also teach parenting skills. They certainly model positive parenting skills. Again, it's all about empowerment, not creating dependency, not doing for, but doing with, and showing them how to do for themselves. And also helping parents to partner with providers. Many times parents are angry, frustrated. That is absolutely normal because of sometimes the protracted length of time it takes to get services, or the fact that they go to so many different places and get asked the same questions over and over again. And so they begin to view all providers in one category, and we say, no, you've got to partner with and be a partner yourself with providers. Equally important is what a parent support partner is not. It is not a substitute for clinical services, and it's not an aid. It's not somebody who transports people, although it could be as a part of their role. But the role of a parent peer support provider is that of a skilled professional with very unique qualifications, skills, and roles. The services provided by parent peer support providers are individual or group peer support. As a matter of fact, we surveyed the family support organizations across the country and found that about 98%, this was the primary service they provided, with parent peer support. So individual, one-to-one, or group, across multi-child serving systems. And the levels of support are range. In some places, it's manning a hotline, an 800 number. It could be family navigation, where you're helping a family perhaps with a special education issue, to all the way to intensive wraparound for a child with significant behavior needs. So states and communities are looking at parent peer support not as one thing, but across a range. And in some places, it focuses on intensive wraparound. In other places, it really wants a whole range of family support, from low end to high end. I mentioned that education and training are also vital roles for parent peer support providers. Community outreach is equally important, because getting out there to connect with families and get them to come in or informed about parent-peer support, what it can do for them, is key. I said many times over that I don't think parent-peer support providers ever take off a weekend. They're always, or an evening. They're always out there at community fairs or doing presentations at churches or whatever. The commitment is beyond belief, and it stems from the fact that they're doing this they're doing this for their kids, but also to help other kids and families in the same situation. I always said in Maryland it was not a job, it was our passion. And parent organizations and peer support providers can play a vital role in public policy. And that can be in many ways. It could be legislative. It could be participating on policy committees. It could also be bringing the voices of families to public policy tables. In Maryland, we often did focus groups with families around issues that we were getting a lot of calls about. And then we would take the results of those focus groups and take them to policy people and say, look, this is what we're hearing from families out in the community. So they can play a vital role in that as well. So why is parent-peer support important? In May 2013, the Centers for Medicaid and Medicare and SAMHSA came out with a joint bulletin identifying parent-peer support as one of the key services that can enable children with complex needs to live at home and participate fully in their family and community life. So that was in 2013. We've seen a lot of states now use that bulletin as a means to Medicaid the parent-peer support services, and we'll talk about that a little bit later as well. Workforce predictions are that peers will comprise 1/4 of the workforce in behavioral health. And I don't have a year there, and I should have. I'm going to estimate like in the next 10 years. It's certainly a growing workforce. And the other thing is that the volume of work being done is incredible. I think very much underestimated. Our very conservative estimate as a result of a survey of 31 family organizations showed that they had served over 109,000 families in 1 year. We think it's considerably more than that, but that's a lot of families who are being served through parent-peer support. And that's critical, especially when accessing services is so often such a barrier, that making these services more available can be a significant way to help families access the care they need for their children. When we talk about peer support, we've kind of dissected it here. And it's important to think about the different components of parent-peer support and the infrastructure that's necessary for parent-peer support to be successful. So I know we have a lot of people on the phone. You'll be able to see this slide, but it's got a lot of little boxes on it. And on the left-hand side, it's called infrastructure. And down that left column, it talks about employment, training, supervision, location, and certification. So these are all the different components of peer support that as you're building peer support or providing peer support that really need to be taken into consideration. So as we looked across the country, we saw that peer support was being provided through very different entities, vehicles maybe. So the first one, the next column over going down, is the family organization. I mentioned those, the network. And so the family organization employs the parent-peer support providers, trains them, supervises them, and they're located within the family organization, although they could be in a regional office, but it's all located within the family organization. We consider that to be the most authentic kind of peer support. the certification for that could be a state certification or a national certification. Third column or middle column is in some places, and I think we're seeing it more in local communities, government agencies may actually be hiring, employing peer support providers, training them, supervising them, and they're located within state government. And again, the certification could be done at the state or national level. Those of you who may be familiar with the Federation of Families has had a national certification program, but we're seeing many, many states develop their own state certification process. And then we're also seeing peer support embedded in private providers. There's some states that are actually requiring by law that every private provider has a peer support provider. So the provider employs, the provider provides the training, supervises, and they're located in the mental health clinic or the whatever the mental health program may be. And again, the certification could be state or national. More frequently, we're seeing a blended model where they may be employed in either the family organization, government agency, or private provider, and the training may be provided by a completely different entity. So they may be hired by government agency, but the family organization does the training. There may be co-supervision, and they may be located either in the family organization, a provider, or a local or state agency. So there are many variations of parent peer support across the country. So we would just say to pay attention to, in your site, each of these components and what works best, and what not only works best for your site, but what would make parent peer support the most successful. Because it's very difficult at times to operate as a parent peer support provider when you are not connected to other parent peer support providers. It also can lend itself to the role of the parent peer support provider being redefined to that more of an aid rather than a professional. So we want to caution people to, if it's embedded either in a government agency, private provider, or some type of blended model, that these components are attended to so that the parent peer support provider is not themselves isolated from other parent peer support. The supervision they're getting, the training they're getting is all appropriate to their role, and that the host environment also understands the role of parent peer support providers. That's very key, all of those elements to the success of parent peer support. So there are some advantages, we believe, to a family organization being the delivery model, in that I mentioned it's, we believe, more authentic. The youth and families themselves doing the peer support see themselves as part of a bigger picture. It also provides a unified voice for families, and however, the cautionary tale is that sometimes family organizations operate on very small budgets, and the infrastructure necessary for supervision or billing may not be adequate for it. So that's one kind of caution. I mentioned the possible isolation as a result of being embedded in a provider or government agency. So I'm going to, the slide on financing just came up. Before that, I just want to mention that we just came out with a tip sheet called Assessing Readiness to Become a Parent Peer Support Provider. We're often asked, you know, if we're looking for parent peer support providers, you know, what are the criteria? What should we be looking for if we know that they're going to be out there working with families? So this is available through the TA network. and it's also available on the FREDLA website. But we have minimal education requirements, a high school diploma or a GED. The lived experience is, as I said, paramount. But really, also their ability to recognize that their personal lived experience, both positive and negative, has fostered their personal growth. So in other words, they have moved beyond the anger stage, the frustration stage. Not to say they may not still be in the thick of it with their own child, but they're able to get some distance, some perspective on that. And the capacity to think beyond their personal family needs to understand and be available to other families, as well as to partner with other agencies. So there's lots more on this tip sheet. And as I said, maybe, Colin, you could put up the link to the tip sheet, which is on the TA Network or FREDLA website. But you may find that very helpful. Now, financing, always the rub. So as we look across the country, most parent peer support is grant funded through System of Care grants, state block grants, state and local funds. SAMHSA puts out statewide family network grants, as well as the other SAMHSA grants all have a component in them that could be utilized for parent peer support, like Project Launch, HDI is Healthy Transition, Project Aware is School Mental Health, as well as grants through other system partners. So grant funding, and since 2013 now, more states are jumping on board to get Medicaid funding, through using waivers or state plan amendments. Another resource that could be helpful to you is Medicaid financing for family and youth peer support, a STAN of state programs that can help you. It's a little bit dated. I think it was done in 2012 as to where your state might be with regard to Medicaid financing for family peer support. That Medicaid payment could be a direct payment from Medicaid to the provider entity, the family organization or the provider organization, or it could be through an MCO network provider, or in some states we're actually seeing a subcontract with, say, a provider organization, and then they subcontract with the family organization, either Medicaid or the MCO subcontracts. And then we have also seen Medicaid administrative dollars being used to support parent peer support. We also published a recent guide to family-run organizations who wanted to implement Medicaid billing for parent peer support. We can get you that link as well. That publication came out maybe a month and a half ago. It's also available on the TA Network, and we can get you that link again. So the cautionary tale with Medicaid is that the Medicaid rates for parent peer support do not cover the entire cost. They cover the cost of perhaps the individual, but it really doesn't cover the overhead, the supervision, the training, even many of the personnel costs like days needed to, for supervision or training or conferences that we are seeing across the board very low Medicaid rates for parent peer support. So that means that to have a viable parent peer support, additional funding is needed to support that infrastructure, be it the family organization or even within a provider organization. So the rate itself, would pay for the time of that parent-peer support provider who is working with the family, but not the time that they need to, attend training or supervision. It depends upon the rate, obviously, and there are a couple of states that have a higher, more reasonable rate, but pretty much they're very, very limited rates for parent-peer support. Not a money-making deal at this point. So this is my contact information if you're interested, and I will be sure to send the links to Neil, who can get them out to you, or Colin, who can send them out on the different documents, the readiness tip sheet and the Medicaid. So with that, I'm going to turn it back to Neil, and maybe there's some questions out there that people have.
So thank you, Jane. I really appreciate it, because as those of you who know me well won't be surprised to know that I planned this for almost 2 days with Jane, as opposed to giving somebody like months and months of notice. So with like a day of notice, Jane was willing to sort of hop on and sort of not only hop on, but, in Jane's way, share some really powerful information. So I'm going to ask folks just for a sec. I see we'll get you the PowerPoint. We'll make sure we get it sent out to folks. Jane, you're okay with that, right? If we send the PowerPoint out?
Sure.
Okay, great. Maybe I'll start with a couple of questions so folks have a minute or two. We have about 60 folks on the line to formulate their questions. But, as I was listening, Jane, the thing that sort of struck me was in terms of the financing of this. And I know we actually have some folks on the line from states and communities that are doing some very similar kind of work, so I'm hoping they'll jump in too. But, when I looked at the sort of funding sources, I was struck that there are things that are sort of come and go kinds of things, like grants, like launch grants and things like that. And then there are things more like a block grant and state and local funds, and as you just talked about. So can you talk about sort of how some states have been able to get this into more solid, and I understand that block grants and state and local dollars also change, but can you talk a bit about how some states have been able to get this into a more permanent sort of fund versus others?
I don't know if we have anybody from Arizona on the line, but Arizona has done a good job of being able to sustain that through their Medicaid, and it's really got to be a combination. It's got to be a blend. And you're right about the grants coming and going. But state dollars are crucial, and some states allocate some of their block grants. So that's kind of consistent funding. It's always subject to being cut. But a blending of the Medicaid for the actual service and the state dollars for the infrastructure. The other thing that we're finding helpful is child welfare dollars to be able to support this service as well has been very helpful. And then Massachusetts, I don't know if we have anybody from Massachusetts, but Massachusetts is the state that by their lawsuit settlement requires that every single provider have parent-peer support embedded in their organization. So that has to be sustained. So I'm not sure how Massachusetts builds for that, but I would say it has to be a combination of funding sources. The system of care grant, the launch grant, whatever, are wonderful to be able to get to build it, shall I say.
Yeah.
But sustaining it has got to be, and we're seeing a lot of change in administrations in states, governance, governors, legislatures, and so some of our long-standing organizations have lost some ground as a result of funding cuts. So last week I met with 44 of the child and adolescent mental health directors across the country. And I have to say, they were so completely on board with both parent peer support and youth, young adult peer support. They were, you could tell they were all fighting very hard to if they had it, to preserve it, and if they didn't have it, to try to build it.
Well, that's great. Well, that's good to hear. And so I don't think we have folks from Arizona on. I will not call them out by name, but I do know we have folks from Massachusetts on. I'm going to let them decide whether they want to sort of hop in or not. But in terms of child welfare dollars, were there specific sorts of pots of those? You know, was it a particular fund out of child welfare, or just in general you're saying that child welfare oftentimes has some dollars that sort of comes?
Yeah, it depends upon the states.
Yeah.
And I'll have to look into that. I'll get you that information. I can do that.
Okay. Thanks, Jane.
I don't know exactly like it is, you know, Title 40 or whatever.
No. Right. No. I just, if you knew it off the top of your head, that's fine. So a couple things, folks.
Neil.
Who's that?
It's Kate Roper from Massachusetts.
Oh, thank you, Massachusetts. Go.
There you go. Kate Roper, legend, is going to tell us what the deal is in Massachusetts.
I will do my best to tell you what the deal is in Massachusetts. So in terms of we have, as Jane mentioned, we had a lawsuit called Rosie D. versus, now it's been 4 or 5 different governors. And so as a result of that, it was an EPSDT lawsuit that kids were getting stuck in emergency rooms and residential programs because of lack of community-based services. And so part of the settlement for that was to require family partners and peer mentors in some cases as part of intensive care coordination for kids with a serious emotional disturbance. And that is part of a whole wraparound model. Family partners can also be accessed through another lesser intensity service called in-home therapy, as well as some outpatient, but it's most frequently used for intensive care coordination. They bill through Medicaid. It was a state plan amendment waiver. So the behavioral health providers who are part of the ICC, intensive care coordination, they're called community service agencies, and they're the only ones who can employ the family partners. The infrastructure piece is a little mysterious to me, and it's partly because I'm not so engaged in that system. But there are some different sources of training and support, including recently curriculum was developed with a local Institute of Higher Ed for family partner training, which is really exciting. My role in this is I actually run a launch and now a launch expansion grant where we employ family partners partnered with early childhood mental health clinicians in primary care settings. And we also have a young children's system of care expansion that does that as well. Again, we've struggled with sustainability, especially for the launch where we're really working more on prevention and kids who aren't even at imminent risk for SED, but we're really trying to prevent them from ever getting into that situation. So we're exploring looking at our global payment and, again, it's hard enough to get with Medicaid reform when it's about payment reform to get them to look at kids at all, much less young kids. But we're doing our best and keep turning over more and more rocks.
That's great. Thanks, Kate. I appreciate that. Other folks on the line, questions for Jane, sort of more global sort of comments or things about the what you're doing? I'd be interested just sort of overall in hearing how you all are trying to bring not only families in terms of providing services, but just in general, this has been a challenge for some of the folks in the early childhood world. Maybe you could type in the chat, or I think the lines are now open. Is that correct, Colin? Colin's line's not open, so yeah.
I think lines are open.
Oh, right, yeah. So otherwise, I wouldn't be able. Otherwise, maybe just Kate plays in my head. So I assume everybody. So yeah, how folks want to sort of jump in?
Can I
go
say
ahead, Kate.
one thing?
Yeah.
One thing that has been a really exciting unintended consequence for us is that many of our family partners not only had lived experience, but were from a similar cultural and linguistic background to our families.
Yeah.
And we provided a lot of training, technical assistance from our National Federation for Families branch, as well as group supervision as well as individual supervision. And a number of our family partners ended up pursuing higher education, and a couple of them are about to become clinical social workers. And so we're losing them to the family partner business, but we are having them become, bilingual, bicultural social workers with lived experience. So that's thrilling to us. And we've also done a lot of parent leadership work with our families, supported by these family partners, and we had a lead family partner as well. And now a couple of our families have taken the family partner training that I mentioned at the Higher Ed Institute. So we've had this really nice sort of career ladder that was something we had planned to do at the outset of the project.
That's great. Yeah,
that's
great
fantastic.
Yeah.
And I saw that too in Maryland. It's absolutely incredible, the growth that you can see in a family member who realizes through their journey they can help others, and they go down that path. It's wonderful. Yeah, and your point about the cultural, being a cultural broker or bridge, it's spot on. Good point. Yeah.
So we also have a comment written in here. Margie, I didn't know if you wanted to actually say it, but it looks like you typed it in. So Alameda County in California, which has had the benefit of I call it a benefit because I'm not the one who has to run these things, but had the benefit of a System of Care grant and a Project Launch grant, had a total of 43 family partners employed by the community-based mental health organizations and one family-run organization, and the family partners bill Medi-Cal, which needs to be signed off by a clinician. And 14 of the family partners are in early childhood mental health agencies, and there are challenges besides financing, which they continue to work on. So I don't know if folks, Margie, I don't know if you want to say a little bit more about that in terms of the challenges, or you feel like, no, just leave it like that. We'll leave it like that. Margie, you just type in. I'm not sure if you're on by phone or not. And then Priscilla is asking, besides becoming case management certified, what are other ways family support providers in System of Care in Oklahoma have the ability to bill Medicaid? So I think we have like 654 people on from Oklahoma, so I don't know if there's somebody who can actually answer that. I don't know Oklahoma's sort of ins and outs. So I don't know if there are folks who have some thoughts about that or not.
So is Oklahoma, Priscilla, are you saying that the parent peer support providers become certified case managers? Is that what you're saying?
She's typing.
Can you folks hear me?
Yep, we can.
Yeah.
But make sure computer speakers are turned off, folks, because we'll hear an echo.
In Oklahoma, at least the family support provider can do Medicaid billing if they become case manager certified at level 1, which is, I believe, an associate's degree with at least 60 credits or 3 years of experience working with providing social services. So besides the case manager certification, level 1, is there another way that a family support provider could become, could have the ability to bill Medicaid?
This is Shannon from Oklahoma. I'm the manager of Infant and Early Childhood Services, and I work for the Department of Mental Health. There is a separate certification for family support providers not tied to case management, where you have to go through, it's through wraparound, you have to go through RAP 101 training, and then we have a separate family support provider training. And it does require the lived experience. There's an application that goes through it. It has to be through a Systems of Care or health home site, and it does allow you to bill Medicaid, and it's separate from case management. A lot of family support providers are eligible for case management level 1 certification, but that kind of serves a separate purpose.
And then this is Priscilla again. I was wondering if that certification you just spoke of, is it only for the health home modality, or can the wraparound work as well?
It's for both. So we had that before health homes. But you can send me a separate email if you want, Priscilla, and we can talk about that. But, yeah, we've had the Medicaid Compensable Family Support Provider Code for a couple of years now.
Okay, thank you so much.
Awesome. I think we just solved Oklahoma's problems. That's great. I love that you guys are connecting. Other thoughts, questions, comments? Because I'm also mindful of Jane's time. We don't have to sign off necessarily, but I don't want to keep Jane if folks are sort of are done.
Well, I wanted to get back to a point that Margie from Alameda County, I am not sure if this was the challenge she is referring to, but I do want to talk about the issue of documentation for parent peer support providers, as it comes up frequently, especially regarding documentation for Medicaid billing. And that is often a huge challenge. I mentioned that when you look at readiness and qualifications to become a parent peer support provider, you know, computer skills are not usually a criteria. Writing skills are not usually a criteria, and they can sometimes be the downfall of a parent peer support provider. I had a personal experience in the organization I ran where I had someone who, unbeknownst to me, struggled with that issue and therefore avoided all documentation until we uncovered that the hard way. So those are challenges that we often see in helping parent peer support providers acquire documentation skills. It sometimes means changing the documentation form so there are more checklists, you know, running intensive training on how you document things. And then the other point that's raised here is about needing to be signed off by clinicians. That's an interesting point in itself, and also goes back to even the supervision issue. And I mentioned that we believe that peer support needs to be supervised by another parent peer support provider who has the additional qualifications to be a supervisor. That doesn't mean they can't be co-supervised by a clinician. So there's many different pieces in the point that Margie raised about other challenges of parent peer support providers. So thanks for bringing those up. And I see she has to sign up. So.
Yeah. So some of you are hearing from some of the early childhood alumni. So Alameda, Margie in Alameda. Sorry, Margie. I have a neighbor named Margie. And Kate and folks in Massachusetts are folks who've had these grants and have really thought this through. I will mention they're not on the phone, but the other place in terms of an early childhood site that really thought this through was in Alamance County, North Carolina, that had a very similar model to the one that Kate and Mira and other folks in Massachusetts talk about, in which a family partner was placed with a mental health clinician in primary care office, and really in North Carolina it was in private, huge pediatric practices, but those were folks who were also, they were figuring out how to bill for their services and things like that. So I think there's a couple of examples around the country that are really nice, and it looks like Margie's been kind enough to volunteer the services of somebody on her staff. So there's a person out there to ask. And now, again, keep in mind, this is about early childhood, and I think, Jane, you sort of raised an interesting point in the beginning that I always try and, remind folks of this, that in the early childhood systems world, sometimes we're talking about families that have had no experience in the system. This is, their first experience is that they have a child that gets referred for early intervention services or, is in Head Start or maybe is starting to have challenging behaviors, things like that. And so that's been the challenge for some folks in this work is we don't have families that have 20 years of lived experience, as you sort of described with your 5 and with your daughter in particular. I've heard you talk about her. I do like what Kate sort of put here for this is that, viewing family partners as your colleagues and not needing clinical supervision, that there's plenty of people out there who have enough lived experience and some of the other factors, Jane, that you described that sort of, qualify them to provide the kind of supervision that family partners may benefit from. So that's great. Thanks, Kate.
Yeah.
Other questions or comments around this issue? We can sort of stay on if folks have other subjects or topics that they want to just touch upon, but I think it's been really valuable to have Jane on here, and I don't want to sort of have her leave if other folks have any questions for her. Of course, she mistakenly put out her email, or on purpose put out her email, so you have a way to connect, and some of the resources in addition to just her PowerPoint is being able to connect with Jane, who's a partner with us, obviously, in the TA network. And now you've seen a couple of our early childhood system of care alumni who've offered up, the ability to sort of connect with them as well. So last questions or comments for Jane?
So, Neil, I also think that Colin put up the link to the file that
He
people
did.
can
It's at the
download
bottom underneath the chat.
Yeah.
Yep.
Assessing readiness.
Oh, well, wait. I don't know if he did that. I only see.
I'm sorry.
Just
That's
for the PowerPoint.
Sorry.
Yeah,
Sorry. I'll get
so
the link.
So if we get that link, Colin can sort of get that up, and if not, we'll get it out to folks. We can just shoot it out across our. We put it in the TA Telegram for next time. Okay, so Jane, I really appreciate your time. Folks, if you want to stay on the line, we have time left. I'm not going to force people to sort of stay on the line, but if folks have other topics or issues, remember this is just our community practice call. I've tried to put at least a little topic to it in the beginning of the time we have together, but if there are other things that folks want to just sort of touch on, I'll stay on as well as anybody else who's interested, and if not, then we can sort of be done. But I don't want to keep Jane any longer if folks don't have any other questions for her, although Ashley seems really appreciative, Jane. So with that, Jane, I just want to say thanks, as always, just a great resource. We really, appreciate your time and all this information, and I think a lot of food for thought, a good conversation going. So thanks, Jane. Okay, so folks, we're still, if we want, we still have some time. Are there other things that folks want to talk about? You can type it in. You can sort of call it out. As you know, I'm not sort of big on just making folks stay on the phone. I'm watching people drop off in terms of participants, so I'm assuming that some folks were here for the Jane Walker show and are not as interested in the anything else, but I'm okay with that. Other subjects, content, topics that y'all want to talk about?
I do have a question. My name is Malika Ardi. I'm the coordinator of family-driven practice in Massachusetts.
Okay.
And I'm interested in the training and support that's offered to peer support workers specific to the preschool age, how people are approaching that. I would imagine there's a lot of education around sort of the age ranges, but the challenges that come with that. What are people using, or what frameworks are they using specifically to, I think the parent-peer support role in itself is huge, and just them having a partner in,
right.
in their fight, I guess.
Yeah,
I was a family partner for years and years here in Massachusetts when the CBHI first rolled out. But I guess I'm interested in how are people really making sure that they are offering something different than just, specifically the parent support role for other age groups? Like what are they using or thinking about in terms of training?
Well, so I'll start, and then I'm hoping folks will sort of jump in here, and I know that Margie to get off. But I'll start with this, which is I'm not sure that everybody has sort of got as robust a sort of role and partnership with the family organization in the early childhood world as we've heard described thus far. I mean, I think that there's some great variability and there's a real continuum. So I think that in terms of, I could tell you what was happening in North Carolina, because I don't think there's anybody on from North Carolina, so no one will correct me if I get anything wrong. But, there, families, much as Kate sort of described in Massachusetts, families there were really seen as partners, and so they were involved in all the training. They were trained up. They were part of all the discussions around the clinical trainings that were happening. They were fully informed about the evaluation, all the aspects of the systems development effort, because that is in some ways being a partner, right? If you want to just sort of shunt somebody off to the side and say, we're only going to show you or train you or give you support on particular aspects, that's not really a partnership. And so that was one thing that I know happened in North Carolina, and I believe in Alameda it was pretty similar. But I think what you're asking is much more specific around sort of in their role as family partners, what kind of training did folks get specific to the early childhood world, correct?
Exactly.
Okay. So I don't know if we have other folks. I know that we've got a lot of folks from Oklahoma, but are there other folks on the line who sort of want to take a shot at sort of answering that? I'm not sure if Jane's still on. Yeah, Jane put the assessing readiness file on there as well. That's underneath the PowerPoint there, but it's on there. But any other folks on the line who are sort of have addressed this issue about how do we provide the kind of training and support for family partners around early childhood issues?
This is Shannon again, and I'm sorry, I don't have access to, I can't pull the slides up online, so I'm having to do things over the phone. But one thing we recently wrote for an early childhood grant, and one of the things that we wrote in there that we hope to do with our family support providers and our care coordinators both is allow them to have access to early childhood mental health consultants. We have a pretty good group of mental health consultants because we are a Project Launch state, and so through Project Launch, we have providers through some of the early childhood Head Start centers and elementary schools, but we hope to actually expand early childhood mental health care consultation to our wraparound teams. And so because we have gotten a lot of feedback from family support providers as well as our care coordinators that they do need more information and training specific to infant early childhood. Another thing that we're looking at doing is offering the 0 to 3 modules to our wraparound providers, the family support providers as well, and then having our mental health consultants lead us in facilitation to kind of talk through those modules. So, and I can share any information if you're interested. I can kind of give you guys some ideas of what we hope to do with some potential grant funding that we're getting and things that we've already been able to do with our Project Launch grant. So
that's in Shannon. That was Shannon in Oklahoma, right?
Yes.
Okay. So Shannon in Oklahoma, I'm going to ask you a couple of questions since, one of the areas where I'm spending a lot of my time right now is on infant and early childhood mental health consultation. The dollars that you're using for your mental health consultants, is that coming from grants like Launch?
We do have some of the funding is through Project Launch, but we also have some state funding that we're able to use for that, a little bit of state dollars. And then we have our Child Welfare, DHS, actually provides some funding for child care consultations. So we have something called the Warm Line. So we have a couple of different funding sources for child care consultation.
Yeah, I'm just thinking in terms of sustainability. One of the challenges in mental health consultation is always how they pay for it. But boy, it sounds like Oklahoma's got some interesting ways in which to support their families, Malika, their family partners, Malika, because what we know about mental health consultation is that in the last 10 years we've been able to get, I say we because we at Georgetown have spent a lot of our time working on this. It's gone from sort of a service that's sort of hard to fund, only in early care and education, to what Shannon just described, which is a way in which we might support folks with great mental health expertise in early childhood, making sure that everybody, whether they're family partners or staff in early care and education or all the other sorts of places where we find young children, that they have the kind of support and sort of professional development that really helps. So that's great, Shannon. That's really exciting.
Awesome.
So hopefully, does that help a little bit?
It does. My largest fear is just that there's so much going on in families that very often they go in with a focus on the young child, and then things start to come up and there's some drift, and just trying to keep them focused on trying to not only stabilize the situation but focus on the education the parent may need, or the caregiver, the support that they may need around support and service for the child that is preschool or early childhood age. So
yeah, totally.
We're finding the squeaky wheel gets the grease kind of
always does.
response,
Yeah.
and
That's
so I'm
great.
just trying to figure out how to keep them feeling knowledgeable and focused.
Yeah. Well, so, the one thing I'll say is I totally agree with what Shannon laid out in terms of mental health consultants being made available. I think that the issues I raise are because we know across the country that one of the issues in mental health consultation has been how we finance it. I mean, there's a whole new center on mental health consultation now, a national center. We've developed this toolbox that'll be coming out in the fall, and then we're going to be selecting pilot states and travel nations in the fall to really roll out mental health consultation. And, I think, Shannon, what you described is such a great example of how helpful mental health consultation can be in a pretty broad arena. So I think that that's but one way when we could that we might be able to support family partners, given, there's a whole sort of knowledge base that you need when you're doing early childhood work. So hopefully that's a good help. Good. Okay.
Thank you.
Yep. Other folks, other questions, subjects, topics? It sounds like we had a good sort of strong group here with Jane's topic. Okay, so I'm not going to make folks just stay on the line just to stay on the line. Just know that if there are particular areas of interest, I know one of the grantees actually had expressed some interest in this, and so we hope to have Jane, and we're glad to have Jane join us. If there are topics that you'd like me to get speakers on, to have particular conversations, I don't need to have an outside speaker, but happy to. If there are particular topics or some content that you want to make sure we focus on next month, the month after, whenever it is, just shoot me an email, let me know. We are, we're here to sort of help you all in your systems development. I appreciate everybody's comments and jumping in. I thought it was a good discussion. I hope that you enjoyed what Jane had to say. The readiness piece that she talked about and the PowerPoint that she used are down below this chat box. If you want to download them, you just highlight and then click download. So if nothing else, we will talk in August. And thanks, everybody. Have a good rest of the July, and we'll talk next month.